Do Sanin, welcome to our membership cafe. I am Tanea Watts, your membership coordinator. And I quote, "We have experience that we can safely provide acupuncture to any substance abusing client before any psychiatric assessment is made. The significance of this is that when we do assess that person, we have a calmer, relatively more cooperative and available client." This is from the integration of acupuncture into existing chemical dependency treatment programs, written by Michael Smith and Brian McKenna, from the print of Launching and Running a Program. Launching and Running a Program is a book that is free for members in a digital format. It's found in the NADA articles, or you can purchase a hard copy from the shop. All right, Ruth Ackerman is here today, and we're going to be speaking with her about how to launch and run a program, as she literally wrote the book on it. Ruth's brilliant chapter in this book is called "So You Want to Start an Acupuncture Treatment Program for Detox." So her chapter is called "So You Want to Start an Acupuncture Treatment Program for Detoxification, Relapse Prevention, and Preparation for Counseling." Before we discuss this topic, though, I first need to take care of a little business. All right, this is top of the hour. Ruth Ackerman, can you please tell us a little bit about who you are, where in the world you are, and your relationship with NADA, the protocol, the organization?
All that stuff. Sure. I'm just delighted to be here. Ruth Ackerman, obviously, from Santa Barbara, California, which is the land of the Chumash. And I'm going to return to that because one of our very first efforts in starting a program was to reach out to the reservation nearby to see if we could establish some kind of working relationship with them. And that's a little story all to itself. Yeah, let's see, my relationship to NADA. Well, okay, I'll tell you the long version of, of the story. I don't know how many of you knew my husband, John Ackerman, who passed away this last August, but he was a psychiatrist and an acupuncturist and had learned acupuncture in 1971, which was a long time ago. And he read about Lincoln and the work Mike Smith was doing somewhere in the middle 70s. And by 1979, he had gone to Lincoln and gotten trained. I think he spent 2 weeks with Mike. The thought of it amuses me. They were so opposite. They were kind of like the odd couple. At any rate, he was doing the 5-point protocol in his private practice, his private psychiatric practice. And when people found out about it, they wanted to pull his license and have him lose his hospital privileges. And it was back in the day. So anyway, that's how I found out about acupuncture detox. And in 1986, one of our kids went to college in New York. And when I took him out there, I decided to visit the program at Lincoln. Now what you need to know about me is that I'm a social worker. My background had been in child welfare protective services. I had been working with a nonprofit in Santa Barbara called Calm, and I've been spending a lot of time with their child abuse prevention efforts to create a clinical alternative to child welfare protective services, which was overwhelmed and overburdened and couldn't provide direct counseling services. Anyway, one of the problems in Santa Barbara was that if you were under the influence and you had children, your family could not get shelter in the homeless shelter because you had to be clean and sober in order to get in there. And so families were unhoused with no alternative because in our county, there was no detox. So we would tell people to pretend they lived in our nearby Ventura County because they had detox beds at their hospital. People would go down there, come back, and be able to be admitted to the shelter. So that was the context that I went to see Lincoln for the first time.
Wow.
And I walked in, and Lincoln is, as you know, in an area that looks like a war zone. It's just a bombed out area. Really was tough. And I walked into the into the building, and I saw all these people sitting around quietly. And I asked whoever, I can't remember, maybe it was Nancy Smalls, where the treatment room was. And of course, I was looking at the treatment room because I was used to people agitated, white knuckling, etc. After spending the day with Mike and seeing the overall program, I just knew we needed to do something like this in Santa Barbara. And so that was my introduction. And because I was oriented a little bit to the social services in the community, I thought, how easy is this going to be to just get an agency to add on acupuncture? Because it seemed to me that the logical reward from funding point of view would be to successfully detox people. And well, the way the system is really set up is the more demand for the services, the fewer empty beds, the more you get paid. So it's a weird thing. In a sense, there's a disincentive for rapid success. And particularly when the big bucks were coming from inpatient or residential detox, to think that you could do outpatient detox and be just as or more successful in the long run was a hard sell. So long story short, we, that's me, I hate to say it, forgot about that. I decided that we needed to have this, and it was an educated process. When you read that chapter from Alex's wonderful, wonderful book, Transformation and Recovery, which I cannot, even now, just reviewing it this morning, it's excellent. It's still excellent. It's deep learning. If people haven't had a chance to read this book, they will be extremely inspired and supported by the content, even though it was published in 1994. So the research is certainly not up to date. Some of the references to funding sources is way out of date. The need to go to a library to find the foundation books, to find out what nonprofits fund the kind of work you're interested in, all of that is over. However, the rest of it stands. So anyway, I came back to Santa Barbara and tried to get this attached to an existing treatment program, of which there were 3 likely suspects in Santa Barbara. None of them were even vaguely interested. And so I decided, you're going to have to start one of my own, which I didn't want to do. Santa Barbara has now probably over 1,000 nonprofits. We're a small community. But to be one more nonprofit in this race for money, not where I was trying to go at all. But in order to get the work done, that's what we had to do. So I went to the county drug and alcohol. Every county has a mental health and or drug and alcohol program. And I went to the county director and I explained my interest and tried to find out about existing programs and where we might connect. And for that first meeting, Mike Smith came out from New York to be with me at that initial inquiry. And they were just totally resistant. I mean, I can't even tell you, it was just this side of rude. They just thought this was crazy and they weren't interested at all. And so the strategy that we worked out with Mike's guidance was find a population that is extremely bothersome to the community. Find a population that nobody is fighting funding for. In other words, if this is going to take money out of a nonprofit or another entity's pocket, it's never going to go forward. And so that was very good advice. And what we were after anyway was to find a resource for the pre-homeless and homeless, a barrier-free model. And I had asked Sarah to find this little video that we made. Sarah, can you just show about 1 second of that thing? Because this is what I took around to everybody I could find to talk to. And while you're getting that ready, I'll tell you, I went to every existing provider. I went to, oh, here we go. This is it.
You know what? Let me just reshare so that the sound is, oh no, the sound is going to be shared. Perfect. Okay. Hope it's not too loud for you guys.
For alcohol,
Oh,
acupuncture detoxification for alcohol and drug abuse, a project of the Community Action Commission of Santa Barbara, California.
This is so homemade, it's just astonishing.
Welcome to Project Recovery. Project Recovery is a nonprofit acupuncture detoxification program located in Santa Barbara. It offers detox and relapse prevention treatment for alcohol and drug abuse. Clients are accepted on a walk-in basis. No appointment is necessary. Project Recovery does not exclude clients for financial or motivational reasons. Treatment is available 6 days per week. No psychoactive drugs are used. The program is successful on an outpatient basis, taking about 1 hour per day. The craving for the addictive substance is usually relieved with the first treatment. After a brief intake screening, clients are immediately seen by one of Project Recovery's licensed acupuncturists. 5 hair-thin needles are inserted just under the skin on the surface of each.
I just wanted to have you see a picture of Alex Brumbaugh, who was the author of this book and the director of Project Recovery. And that's who was greeting the client, who happens to be my daughter, who is an actress. As she said she didn't realize how depressed she was until she had the acupuncture treatment, because she felt so much better just in preparation for the video. But anyway, and then we saw just a little bit of Mark Sherwood, who was the acupuncturist that performed the treatment. So I made this, this is extremely homemade, but there was no video from anywhere else. And I got great advice from someone early on. I had gone to the Hispanic community, the Native American community, and the African American community to ask what they need, because they were being arrested in disproportional numbers, and we were looking at an alternative to jail even then. And the social worker from the Black Studies the precursor to the Black Studies program at UCSB said, make a local video. People don't think we have a problem in this town. So if you use something from somewhere else, they're not going to believe it's relevant. And that's why we made the video. And I carried that thing with a portable television and whatever the VCR, I don't even know what the equipment was, in my car, because every time I would schedule a presentation, and I'm not an acupuncturist, so I can't put needles in people. And I live in California, where I'm very skeptical we'll ever be able to do that. But the video was very compelling, only I would go to do the program and their equipment would be gone, or they said they were going to have the video, but anyway. So I learned that you have to be very prepared, and nobody's really ready to embrace this until they see it. So one of the earliest collaborations that I was able to establish was with at the time we had an acupuncture school here. And it was the Santa Barbara College of Oriental Medicine, which was run by Joanne Hickey Tall. And she was my great ally in this. So we didn't have resistance from the acupuncture community. She saw this as a way to educate people about the value of acupuncture and take the onus off of it of being weird, non-scientific, all the negative stuff that they were getting. And that it also was a possibility that we would use their students as interns, which would ultimately train their students in working with this a more troubled population than they would want in their little medical private practices, which was a great concern to her. So this is how we got going. So I reached out to every community agency that would ever have anybody with this patient profile or might be a funder. So all the foundations in town. And it was a great educational experience, particularly in the criminal justice side, because the DA and the police chief understood this immediately. And our police chief, who was so cool and was a great advocate of community policing, spent his vacation up in Portland looking at the program that David Eisen had, and came back and was one of my greatest advocates and was able to get us in the door of a lot of places. Anyway, this went on. I was able to raise funds for 3 years worth of programming. Back in the day, that was almost $100,000 from foundations and other funding sources. And yet we could not get any agency to take us. So we decided to incorporate it as a 501c3 and start our own program. The alternative vision had been to have a group of acupuncturists who would be like itinerant providers, get a van and go from agency to agency, but we couldn't get it. There was no bites. Nobody was interested. So ultimately the Community Action Commission, which at the time, and I don't know if that's still true, every community has one. It's the agency that does Head Start or does senior lunches or these basic, anyway, they loaned us a staff person for a year so that we had an administrative assistant quarter time who began to keep our data and do that kind of thing. And we went to the smaller nonprofits, got some funding, and were able to begin.
Nice.
So that's kind of how it all started for me. I must say that David Eisen and Carol Taub came down from Portland and did a training for anyone in Santa Barbara who was interested in attending that training, and trained acupuncturists in our area. And at that initial orientation, there was a judge from Santa Maria who took one look at this and created the first diversion program in California, a little known fact, but he was a recovering alcoholic. He understood what we were talking about. It gave him somewhere to refer his clients, and it became an essential part of diversion programming here. P.S. All of that, of course, has been lost over time. There's no institutional memory for this at all. Zero. So I don't know if I've answered your questions, but that's kind of how we got started. And I ended up, being president of the board at NADA and then running the NADA conferences for about, Sarah, I can't even remember how many years, but probably 20, 25 years, something like that. And, not as deep in my heart. What can I say?
Thank you, Ruth. That is a wonderful introduction to who you are. I really appreciate that. Let's talk about, so you want to start an acupuncture treatment program for detoxification, relapse prevention, and preparation for counseling. And this is brilliant, and I really appreciated this just as a membership coordinator because it really helps. It helped me, like, when I think about all the questions that I received from people, and when you talked about barrier free, I really had a clear understanding of what that meant. Because for some reason I thought it was just legally, not, the first introduction. Anyhow, you literally give us each and every step in starting a program first, before we dive into that, I'd like to ask you how you come to write this. And then we'll talk about what the components of starting a program.
That's interesting. I had so much resistance from County Drug and Alcohol about this that I had a master's in social work. I decided to go back to school to do some research on the use of acupuncture and chemical dependency, and also to study how institutions change. So I went to get a PhD in organizational development with a kind of special dispensation to do a clinical psych dissertation. And so this is one of the papers that I had to write. And Alex looked at it and said, can we use this? So that's kind of how that came in the book. But the dissertation itself was on the use of acupuncture for pregnant women, because there was all this misunderstanding about forbidden points. And, you know, they've been doing lots of treatment of pregnant women at Lincoln. And we were able to, so I started a dissertation looking at birth weights as an outcome measure. But just the technicality of it was that the intake instrument that we were using was something that NIDA was using at the time. And they changed their intake format about halfway through my research, which made all of it useless. And instead of just dropping it, I was advised to make it into a qualitative dissertation instead. And so I did interviews with women in these various projects. And yeah, so that's available too. I mean, people can look at that. And I get calls on that still because it's not in the literature. We couldn't get that published. The Journal of Pediatrics wouldn't publish it. You know, it's just like, it was very hard for a long time, and I think it still is, to get alternative medicine published in traditional journals.
Wow. All right, so let's go to, thank you for sharing that. Let's go to the chapter. And actually, in launching and running a program, the whole thing is just that we have on the website is just really amazing. There's long-term program sustainability, which is an interesting chapter. And your article starts out with Project Recovery, which we saw a little bit of there, a case study, and you tell us how about that. And that was, when did you start Project Recovery? Was that in the 90s?
1988.
1988, that was it. Thank you. And then when you talk about, you start out talking about removing barriers, and that was where I learned so much about barrier free. Tell us about that.
I have to say that Alex was brilliant, and so was Mike. And the emphasis on being able to walk in and get a treatment and then do an intake came from all of us, but primarily from Mike's experience in New York and Alex's ability to convince the people he had to work with that that was just a swell plan. Because we didn't want any, we'd have people come to Project. Mike told me about this and I thought, oh yeah, right. But no, we had the same thing where people would come to Project Recovery who were probably dual diagnosed or just on the distrustful and even paranoid side based on their life experience. Believe me, whatever the underlying pathology is, don't ask me. But, they thought that there was medicine in the needles. And so there were people who would come for 6 months and just hang out during this treatment session before they would be needled themselves. It was unusual, but it happened. And we attracted a lot of dual diagnosis clients. The barrier-free, meaning you don't have to speak English, you don't have to want to be there. But if you were mandated, you just had to show up, that was okay with it. All of that, however, changed when we lost control of the nonprofit. When we finally were subsumed by the agency we ended up with, they saw that when we wanted to be self-sustaining, and there was Medi-Cal money available, and there was community money that had to do with treating the homeless, et cetera. And we turned out to be a part of an integrative program, which we had said all along. This is not a standalone thing. It's not about acupuncture, but acupuncture is the core of the treatment. And so all the counseling and all the other aspects grew up around it. But it turned out that this was pretty much the money maker for the agency. And they began to attract insurance clients and DUI contract stuff. And pretty soon, if you didn't have the money to come into treatment, you couldn't get treatment. And we tried to get the nonprofit back from what had become Project Recovery in that agency, and we couldn't. And there was a non-compete clause, in fact, that we didn't really realize when we finally closed our nonprofit and they took us over. And it was a 5-year non-compete. And so we couldn't set up alternatively, which we had really tried to do, to become barrier-free. But by then, they would have been our competition for the money. You know?
Wow.
Very complicated. I don't know if that was what you were looking for, but that's what happened.
That's great. Thank you. I'm glad you shared that. Okay. And then, I'm sorry, one moment here. And then we go into, I think the next thing you talk about is what to tell an audience. And I think the question I asked you was, how does one pitch to their overlords if they are planning on providing NADA within an organization? Or if you're going to, one piece of advice you had in there was like, don't send out mass mailings, that sort of thing.
Right. We tried to find a personal connection to everyone that we were presenting to or asking money from. And that meant we had to make some alliances. We had to get to know some people in the funding community in order to do that. And nothing worked as well for us as having an acupuncturist do a demonstration for a small group of people. So, you know, I can remember back in the day inviting a whole bunch of people to lunch, for example, and someone would do the acupuncture treatment. And we experiencing this thing is a whole different level than seeing a video about it, let me tell you. Mm-hmm. And it was very persuasive.
Hmm. Nice. So where would you suggest people start if they want to, once they've been trained, they have this idea, get trained in NADA, and then they want to open up a clinic or a program, where would you suggest they start?
I would suggest that they start by getting a bunch of people who are interested in serving the population they want to serve together, creating a nonprofit board if that's what the direction that they're going to go in, and have it cover the, you know, have the accountant and the attorney and the physician and the funders and have those 10 people or so become your kitchen cabinet that can give you the direction and have the connections to move you to the next point. Because doing this alone is, I never found that to be too successful. It really, there's nothing like having a whole band to get you forward.
Yeah, that's wonderful. Thank you. I had a question in there too, and then it like left me. Oh man. Oh, it was what you just said, but you do have where to locate the program.
Yeah, well, we tried to be where the people were, you know? So my ideal of where we ought to be, there was a little building right next to Needle Park. It's the place that you would get your dope.
Yeah.
And we just wanted to be right there. We could.
Yeah.
And of course, that it was no risk, because no matter where we had, my life experience has taught me, no matter where the recovery program is, the dealers are going to be standing outside the door after the meeting. You know what I mean?
Mhm.
We wanted to be somewhere where people could access us without needing transportation,
Mm.
which was
Yeah.
a huge issue in our town. Very difficult to get around. And I would say the same location today if we could get back in there,
Mhm.
because that's where Project Recovery ended up being. And, but they have no acupuncture anymore, as you know.
Yeah. Yeah. And I had, it was something you said after gathering the population and then was it between nonprofit and that? I don't remember now.
And I have a question from the chat I can bring in.
Yeah, that'd be great.
For that now, or
Sure.
So the question is, what should programs look for while increasing their size or collaborating with other agencies?
I don't know if I quite understand the question.
Miles, feel free if you want to unmute and clarify or add more information.
I apologize. I think it fixed my my spelling. What pitfalls should programs look for while increasing their size or collaborating with other agencies?
Oh, great question. Our greatest problem at Project Recovery was the clinical staff that was hired, where folks had not experienced much acupuncture, and particularly those people who were, some of them, old timers in recovery, who felt that it couldn't be a softer, easier way, and that somehow the acupuncture was creating a softer path to recovery. When the staff has not really bought in to the acupuncture component, that's difficult. So that's one pitfall. The other pitfall that we certainly experienced was that the agencies, and we're in California, right? So it has to be a licensed acupuncturist. They didn't employ people directly. They were contract workers. So they weren't part of the ongoing culture of the agency. They weren't at the staff meetings. They weren't, there when the police were coming for the esophageal bleed and everybody had the trauma. They were just outliers in a way, even though they were there 2 hours in the morning, 2 hours in the evening. They were the go-to people. They were still marginalized. And then when funding got cut in 2008, the reason they don't have acupuncture anymore, that when the economy went down, all the funding for these nonprofits really became extremely competitive and minimalized. And the first thing they did was take a red line and cut all contract workers. They didn't reduce the employed staff, but they got rid of all the acupuncture because they were contract workers. That was really problematic. The other thing that was tough in the beginning was the fear of liability by the agencies. So it was really important that the acupuncturists had their own liability insurance going forward, because that took some of the worry off of the agency. Because most of the idea that you're going to insert a needle and break the skin makes you a medical problem from a malpractice point of view. But we did that part, and that was the irony, because they were contract workers, they could carry their own liability insurance without exposure for the agency. The agency, however, we had one case, I think we were open from 1988 until 2008. We had one case of a double stick where, a needle had dropped on the floor, believe me, it's not in my description of how a program should be run, but there were barefoot clients there because, don't ask me, but anyway, someone stepped on a needle, and pretty soon the agency, I think that was another reason they were thinking of getting rid of the acupuncture when it happened, the 2008 World War I. Does that answer your question, or?
Yes, it does. Thank you.
Mhm.
I have a question. It's with regard to what's going on with COVID and actually shipping from Asia of needles. So the needle supply do you?
You
We've
may have
lost
gotten muted in the
muted,
middle of
Robin.
speaking. Because we don't hear you anymore.
Okay.
Did you get, is there experience of people having difficulty with getting supplies, needles supplies?
Right now, I don't know because we're no longer up and running, but I'm affiliated now with a wonderful organization called Healing Opportunities, which provides NADA protocol treatment to agencies for their staff. For example, the homeless shelter. We provide the NADA protocol for the staff, not the clients, but hopefully the staff will become enamored of the treatment and it'll spread. Similarly at the neighborhood clinics or other similar kinds of agencies. But it's a very small operation, so I don't think we have any way to measure.
Ruth,
Okay.
I have a question for you. I'm wondering if you can comment on how you think starting a program changed, if at all, from 30 years ago to today. What differences you've seen?
Such a great question. And you know, I was so discouraged reading this chapter because I could be doing this today, the same thing. In fact, I just kind of was a kick in the pants because I'm thinking like, how are we gonna, there's a great emphasis on diversion right now, right? And how to get the word out about this treatment and where it'll be an enhancement is just very challenging. It means you got to establish these personal relationships, go and sell the product, convince the agencies who are doing the drug and alcohol treatment that this would be an add-on, an asset to their program. It was interesting. The other thing, I think that there's a lot more awareness because of the encampments and the problems with lack of housing, that on the people who are providing housing are more and more aware that people making the transition from the street into housing need a bridge. And it's that bridge, I think, where acupuncture could be extremely helpful. During COVID, it's really tough. It's been very difficult. They've started a bridge program, actually, from the emergency room, transitioning into treatment, transitioning into housing. But because of COVID, we haven't been able to get in there to have a meeting, much less demonstrate the services. But yeah, it's real similar. I need an up-to-date video. Luckily, we've got a lot from NADA. And, a dog and pony show that, hello, here's something that you might want to be interested in.
Ruth, I want to let you know that Heidi Brumbaugh joined us a little bit ago. So I wanted to just introduce Heidi into the conversation because she is Alex Brumbaugh's daughter. And Heidi, if you've unmuted, we'd love to hear from you.
Hi, Sarah. Hi, Ruth. It's great to see you
hi,
again.
Heidi. Yeah.
I really appreciated I really appreciated the invitation, and I missed the first part. I must have been on the wrong time zone or something, but I'm joining from my car Zoom. But anyway, it's interesting that, the stuff that my dad wrote about, 80 years ago, transformation and recovery. I mean, all of that stuff is really valid and continues to be valid because it's not about technology or anything. It's about acupuncture, which is thousands of years old, and addiction, which is something that, we're still learning about. But I think the lessons that he applied in transformation and recovery are still valid now. And I just also, it sounded like I'm coming in the middle, but it sounded like you were talking about trying to convince people of these programs. I would always refer them to the series that he wrote at the very end of his life. I know he was editing that series the week before he went into a coma and died. And that was my first contact with Sarah. Was I was trying to pick up his email, and she said, "Alex, we need some edits." And I'm just like, Sarah, no, it's not going to happen. But that was this article series that shows the rigor of acupuncture and drug treatment and addresses all the concerns that somebody might have about what is acupuncture and why would this even work. And so I would strongly recommend having that in your fist when you go and talk to the skeptical people about bringing acupuncture into the treatment.
And Sarah, that's available, isn't it? You have it?
I'm going to put a link to that in our chat right now. Thanks for bringing that to our attention, Heidi. That's great.
Anyway, thanks for having me. Nice seeing you. Are there a lot of people here? I can't tell.
Yeah, there's almost 50.
Okay. Hi, everybody. So, the other thing I wanted to say is just, be wary of those deathbed promises, because the last thing I told my dad was that I would get Praxis of Recovery published, and it's published. So you can buy it from NADA or you can buy it from Amazon. And it's a great guidebook for anybody that's setting up treatment.
It's excellent, for sure.
Thank you so much for sharing. I really appreciate that. And one of the things that Alex had also talked about along with Michael Smith too, was tracking and outcomes. And I wanted to touch on that because I'm hoping you guys can share a little bit more about that.
Well, one of the great efforts has been the data collection, not only from, for example, Project Recovery, to be able to justify its existence over time, but also between projects nationally and internationally, to have some kind of similar intake and progress and outcome measurements, so that there'd be a more robust scientific, most of this stuff is anecdotal. And the thing that sells the program typically has been, for us, the old articles by Pat Culleton and Dr. Bullock that appeared in the Lancet in 1987 and 1989, because those are medical. They appeared in extremely prestigious journals, and we kind of haven't replicated that. We've been in Chinese medicine journals, nursing journals, but anyway, that's been different.
Just, I want to point out one thing when you're talking about research and outcomes, and Alex talked about this a lot in Praxis of Recovery, is be careful what your research question is, because recovery is not one thing that happens and then stops. So if you want to talk about long-term, 10-year, 5-year, whatever, acupuncture might help the most at the beginning, keeping people into the beginning parts of the program, getting them past the cravings and the worst of that. And as we all know, that is a necessary but not sufficient, aspect to recovery. So if you're gonna collect research and design research questions, be sure to kind of say, maybe not, is acupuncture good for addiction? but is acupuncture good to get people past the first few weeks of craving? And the answer to that research question is a little bit more finite, and I think you would see a little bit stronger results, because if you try to look at like 10 years, there's so many confounding factors that would be happening that you might not be able to, pinpoint acupuncture as the linchpin of that.
Right, and let me build on that for a second, which is the biggest key is program retention, and that's very measurable in the
Right.
acupuncture programs. And that's what's so highly correlated with, quote, treatment success. And treatment
Right.
success is measured in crazy ways, let me tell you, by various funders or agencies or whatever. And it usually means, can you keep somebody in a bed for 45 days?
Right.
That's what they're looking at. And so program retention is very big and an easy measurement. But it has almost nothing to do with long-term recovery. Oh, well.
Yes.
It kind of does, though. You had talked
Yeah,
about that,
That's true.
it's like,
And certainly the model of Project Recovery was barrier-free in the sense that we did not exclude you if you had failed treatment. So you could start treatment with us and be there for a little while and relapse and come back and come back and come back and come back, because Alex was very clear in his vision, which is recovery is marked by relapse. And
Well,
that
and you never know when that last recovery is going to be the one that gets it. I mean, you say, relapse, come back, relapse, come back. That last time is going to happen one day for those people a lot of the times. So,
We've got
but
one more
you-
question. I'm sorry, Heidi.
Sorry.
I don't mean to interrupt. Go ahead and finish your thought. And I just want to get one more question in before I know we transition to announcements.
I'm not an expert in this field. I'm just going from these long conversations with my dad and editing that book. But, the thing about the 45 days, and maybe that's not, what we would consider like the optimal measurement. But at the same time, you got to give unto Caesar, that which is Caesar's. And it's like, if the funders want those metrics,
Yeah. And I would add that ideally what we would want was 90 days, because as Libby Stout has so eloquently demonstrated in her work, that brain takes 90 days to get right. And so if you're setting up a measure, that might be a great encouragement for people to really aim at 3 months, just like 90 meetings in 90 days. I mean, that's not a mistake. There's reasons for that. Sarah, I'm sorry, go ahead.
It's okay. We've got one person who's asked a question and one more who'd like to ask one. The question asked is, what is the minimum number of treatments that is beneficial that would be needed for treatment? Once a week, multiple times per week?
Great question. Our experience at Project Recovery depends on what you're using and how much you're using. And so what we tried to do was set up the availability of treatment twice a day, every day, if possible. So we would be open from 7:30 in the morning until 9:30 or 10 in the morning to catch people before their day started on their way to work, so they didn't have to chase their dragons the whole day. And again, from 4:30 to 6:30 or 7:30, depending, so that you could come in if you were in acute withdrawal. The frequency of those treatments was there. And then as you tapered off the drugs and the dependency shifted, you could come in less frequently. And then I want to for sure say this, the thing that we found remarkable and never did the research for was that the women in the perinatal program in particular, and in the women's program, we found that if they got treatment at about day 18 of their period, that they were less likely to relapse in that, and it would bring them over that last 10 days till they got their period. Because if the women were going to leave the program, it was very clear that we could see, doing this for 5 years, you get the pattern, is that it was those last 10 days where the women were relapsing. So we just wanted to be sure we tracked him and had him come in and get a treatment.
Thank you for that. We appreciate your answer and your question. And Sarah Jung, would you like to ask your question, please? Unmute yourself.
Hi there. Thank you so much, Ruth. I was wondering what your advice would be if the director of the hospital at which I work is resistant to my pitch, because there's acupuncture currently offered in our rehab center, which is available for public, but I work in the chronic pain clinic. The manager and the medical director is totally excited about the idea, but at the very top of the decision making, place there, they don't feel comfortable with a quote unquote duplication of services, even though we're targeting a different population.
That's a very interesting question. I'm going to just tell you a story. The administrator of our hospital, we've been trying to get a program in that hospital to treat the nurses, this was even back in the day when we still had Project Recovery, and he was just resistant as can be. And then his wife developed some back problems, ended up coming to an acupuncturist who was in our office, and suddenly we had a different kind of entree. But my advice to you would be, don't be shy to ask NADA to provide a voice or a hand-holding or a liaison for someone who's already doing the work. So the president of NADA, for example, can, with a letter or a phone call or an email or whatever, might be able to get so much farther in terms of that program differentiation. And the other thing you can, I like to point out here, is that when we had our conference in Cleveland, at the Cleveland Clinic, Cleveland Clinic is using these modalities for pain, as well as for detox, as well as for, so if Cleveland Clinic can do it, certainly our hospital can do it too. And so there are people there that can be contacted, but I would start with Ken, actually.
Thank you so much. It never occurred to me to reach out to the NADA group directly.
Yes. Don't forget that Mike Smith would fly anywhere to have that conversation with your hospital administrator. And there are many of us who would do the same, because when when David Eisen and Carol Taub came down from Portland, that was out of the goodness of their heart. They were just trying to help us start our program, and then we've done it for jillions of other people. Pass it on. That's what I say.
That's incredible. Thank you for the support. That gives me a little bit more hope.
Yeah, and Sarah, feel free to contact me separately. I'd be happy to strategize this with you.
Amazing. Thank you. I will.
And we have Zoom today, so you can fly or you can schedule a Zoom meeting.
That's true. So true. All right, guys, it is bottom of the hour, very much. We're at announcement times usually right now. My question is, I guess, to the group, because we are having a really good discussion, if you would like to end now or if you would like to go a little further. I don't know what Ruth's time frame is or Heidi's.
I'm chill.
Okay. Because these are all very good questions. I did want to share, and if you read Launching and Running a Program, there is a little section down there where Ruth says, contact the NADA office. And I just really appreciated that. And I have to tell you, Ruth, as I was planning organizational memberships, that's actually, I was researching questions to ask you, and I was like, oh, but this applies over here, and we can use this over here. And so it was just a lot of really good info for me as I think of things that we can develop.
Ruth, I'm wondering if you can just briefly comment on the article that Mike wrote and presented at the NADA conference in 1993, Acupuncture Helps Programs More Than Patients.
Oh, yeah.
And we just enabled this as a resource, resuscitating it from just paper articles, of which we have many copies of that one in our office, to actually being a PDF. And I'll share that right now in our chat for people. But that is an article that I felt he talked to me a lot about, and a talk that he gave that was really, I think, utilized a lot and maybe might be confounding to people at first. Why aren't we not focusing on patients? Why programs? So
Could you just, I have not read that recently. So if you can just mention the highlights from, if you've just read it, but I can tell you a few things that I relate to from that.
I have not read it recently either. I just knew that it was an article that he always gave to people.
Yeah.
To sort of encourage them. Here's my takeaway from it, essentially. NADA is a sort of horizontalizing treatment. So it brings people in relationship that might not necessarily be in relationship otherwise. And that there are many issues with programs as the patients are being treated by the program. If there's issues with the program, then there's not. Yeah.
And actually, two things about that. One, that the essential thing for us at Project Recovery when it was at its zenith was to be sure to treat the staff regularly. Because if there was no buy-in on a staff level, there was no program. They would discourage people. Mm-hmm. They would consciously or unconsciously create a negative environment for the acupuncture. So treating the staff regularly was very important. The business of the sick program would be what happened in our case, where the money became the driver and the focus of the program got lost in the fight for the funding. So that's pretty sick, actually, when you get right down to it. So looking at holding the administrator's feet to the fire and being sure that you're treating the above as well as the client, it's hard work, but it has to be done. And I think that's part of what Mike was talking about.
One of the parallels I found interesting in Alex and Mike's writing was they have both said that acupuncture validates the present. And I think that was in, Alex had 3 things written, and one was addicts have rituals, they validate they're in the present moment, and programs are a lot of times looking at the past and looking at the future, and acupuncture brings us right into the present. And I thought that was just so beautiful.
Absolutely true. Right.
I think that we may want to, sorry, I didn't mean to.
Sorry, do we have any more questions?
I'm realizing that I may have to end pretty soon.
All right. Let's go ahead with announcements, Sarah.
Okay, we wanted to just share 2 important events that are coming up for everybody's awareness who is on our meeting today. The first one, which will be before the next membership cafe, is the second event of our Not a History series, Full Circle. And I'm just going to put in our chat a link for registering for that. That is a free event. It will invite you to make a donation, because what we do is we provide, I would say, a very humble honorarium to the speakers that are there, but then we also want to make a donation to programs that are actively involved in providing NADA services right now. So anyways, please attend that event. This particular event is going to be focused on how Lincoln Detox became set up as a program after the hospital was taken over in 1970. So this is part of a series that we're exploring this year about the very early history before NADA was actually founded as a nonprofit. Yeah, Ruth.
Yeah, I would just say that what's missing in the materials today was the real history of Lincoln's origin, the radical roots, because that would be extremely compelling if you were trying to start a program today. And that's the only difference that I can see between now and back in the day, because back in the day, that was a suppressed history because nobody was going to fund anything that had radical roots. Believe me, things have changed, thank goodness. And so I'd see if you guys can just create a little blurb, an easy read, not many pages, but just, a couple of paragraphs. And that'd be awesome.
Yeah, I mean, I think we're sort of working our way towards that as we really delve into it. We can then go back to the bird's eye view and really kind of synthesize something that I think is going to be much more honoring and comprehensive of that early history, and not just, we read about Dr. Wen in a New York Times article.
Yeah, thank you.
So,
And it'll have a huge impact with funding right now.
Thanks for bringing that up.
Faster the better. Tomorrow.
Right. The second event that we want everybody to know about is actually part of what we're referring to as our NADA immersion. It's not exactly a conference, but there's going to be a series of events coming up in June that we would really love for you to block some time out for. June 11th is a Friday, and we're going to have an event that afternoon or late morning, depending on where you're at, called Responding with NADA During COVID-19. We're really excited. We have the Director of Community Health and Planning for Florida Department of Health as our keynote speaker. And then we're going to have our second panel looking at actual clinics that have been operating during the pandemic. There's going to be 5 of them sharing what they've done, the challenges that they've encountered, how they've set up their space for safety. And then our last panel is going to be self-care using ear acupressure. And we're calling that Everyday Heroes. So if you know people that have been doing that, have been applying beads or seeds to their ears to help them, please tell us. We'd like to really raise them up in this particular part of the panel. And again, the emphasis is Everyday Heroes. We're not looking for practitioners, people necessarily trained in NADA, but everyday people that are using this for their own self-care. And then Saturday, June 12th, is going to be an all-member meeting. We are still getting the time fixed, but it's going to just be 2 hours, most likely late morning Mountain Time. On that day, we're going to announce who has been elected to the member representative position, which is a brand new position on the NADA board, and we'll have a U.S. representative and a Canadian one. So this is the first time that NADA members are eligible to vote for a member of the board, and it will be your member rep. And so just keep an eye out in your email for the nominations for that. And again, we'll announce who those people are on June 12th. So that's our NADA immersion, Friday, Saturday, 11th and 12th. And the registration for both events is in the chat. Thank you, Floyd. I think it's Dope as Death is the film.
Yeah.
Thank you for I'm going to just retype Ruth's email. There's a typo in it.
Thank you, Sarah, for the
You omitted the R for a doctor. The R.
Well, thank you.
We want people to actually reach Ruth.
Yeah, really. Thank you.
And then this recording is going to be available in our library of recordings of other membership cafes, which is in the member resources on the NADA website within just a couple of days. So feel free to use this as the pitch. This is more for our education.
Thank
Hi.
you, Ruth.
Can I make an announcement? There were greater than 5 people on at a wrong time this morning, thinking that Mountain Time there was an error in Mountain Time versus Eastern Time. For notifications that go out, can you put Eastern, Midwestern, and Western times so people can just do a glance and see the correct time for their time zone?
Sure. Thank you for that suggestion. Yeah.
Thank you very much. I saw 9 a.m. and I'm kind of used to the Zoom invitations automatically localizing it. So I didn't even double check. I just put it on my calendar, but I guess I missed an hour or so.
Thank you.
Yeah. Thank you for that suggestion.
Thank you. All right, and we would like to meet you all back here at this cafe, May 19th, where we honor Nada's mothers. Really looking forward to that one as well. Thank you, everyone, so much.
Thank you. That was great.
Bye.
Thank you, Ruth.
Bye.
That was
Thanks,
great.
Ruth.
And thank you,
Thank
Heidi.
you, everybody.